So this is session 24. We're going to talk about another case of pedunculated colon polyp. In the last 2 weeks, I think 3 weeks, we talked about managing a pedunculated polyp one way or the other. And there are different ways you could address this problem and take care of the polyp safely. And also resect it completely. And I would like to invite two of our fellows. One is Zubair Khan, who is a second-year fellow at UT Houston, and Seif Hakim, who is a third-year fellow and currently the chief fellow at UT Houston. And he has a special interest in advanced endoscopy. And he is going to Columbia for advanced endoscopy fellowship next year. In addition, I'm fortunate to have Selvi, Roy, Sylvia, and Sriram, who have been helping with this program. And I also want to thank the support of Dr. Graham. I want to acknowledge support from my mentor, John Stoline, Mr. Charles Butt, for the grant support, Angela Deal, a medical illustrator, and my institution. So here, this is an elderly man who actually underwent his screening colonoscopy a little bit late. As you know that if you delay, you're likely to have a polyp or bigger polyp or multiple polyps. And the endoscopist found a large polyp in the sigmoid colon, and he felt that it was not safe to resect. And he gave them the option of surgery versus endoscopic resection. So what I want to do is, I want to present this case and invite Seif and Zubair to share their thoughts. And also, if there are any technicians or nurses, to also invite them to discuss what they would do when they prepare for a particular type of case. So we'll try to do it a little bit differently so that we can hear from different perspectives. And unfortunately, I did not reach out to my nurses or techs, and this is something that I thought about this morning, and I just added a slide, and I will ask Selvi to look out for any of our nurses or techs who are on the Zoom session and invite them. So here is the polyp, as you can see. A large polyp, actually protruding down from high above. And so Selvi, do you see any nurses there?
So I'll let people, I see one, but I don't want to call on people necessarily. Right. So anybody who is a nurse that maybe I don't recognize, I see one of ours and our, oh, I see a couple. So anybody who wants to, so either Stephanie or Joanne, if you were the nurse in the room and you were seeing this polyp, what are some of the things that you guys should start thinking about? They're both two of our best nurses, really, at MD Anderson, and I'm hoping that they'll unmute themselves and just give some thoughts. There's no right or wrong answer. We just want to see what people are thinking.
Hi, this is Joanne.
Hi, Joanne.
Hi. I would make sure that we have needle injectors in the room, that we have methylene blue, that there's epinephrine in the Pyxis. Sometimes doctors like different choices. There's other type of agents we can use. Some people prefer the indigo carmine, so I make sure we have all those products available. Different size snares. You'd want to have some retrieval baskets. Making sure that there's polyp traps.
I think those are all great points. Yeah.
Cauteries in the room, some coag graspers, plenty of clips that you'll be using after, different sizes.
Uh-huh.
Okay.
That's
Is there a
wonderful.
text
Great
there
list.
by any chance?
I don't see anybody. If anybody is an endoscopy technician, and I just don't know who you are, please unmute yourself and give some comments.
All right.
I don't see any of our
Okay.
techs on there, Raju,
Joanne,
today.
thank
Sorry.
you so much for
Yeah.
joining. I think it's important for us to think through so that we all work as a team and our patients get the best possible care. I think by being prepared, we stay out of trouble. So now I want to ask Zubair to talk about the type of the polyp, the nature of the polyp, and what are the risks of a resection. So you saw the polyp.
Yeah, so it looks like a large pedunculated polyp. I would like to look at the stalk again, but it looks like to be like a big. The stalk looks like to be big, and the surface of the polyp looks like to be there is a lot of the stalk looks like to be narrow. It doesn't look like to be like a broad stalk, but the head of the polyp looks like to be it looks like to be ulcerated. So there is a concern for malignancy here.
Okay.
Yeah, with the Paris classification, I think it's 1P.
Okay, that's good. And I want to ask Seif to talk about how do you resect this polyp? What are your thoughts? And what setup is needed?
How to resect it? Of course, like as Zubair said, it looks pedunculated, and there is a concern for malignancy, but it's maybe at the surface. I think I would first thing I would inject at the stalk, in the stalk near the base, and I would inject epi to reduce any risk of bleeding, especially if there is a suspicion for a feeding vessel or something like that. And the setting that I would do, of course, I would like to pad the patient, and it's likely going to be a hot snare. I don't know if, I think we may be able to do it since it's pedunculated in block resection. So this is something else I would do. And of course, I would prepare different type of clips, and so that it's a large polyp feeding vessels. I think I'm going to clip even the stalk after I resect it, even with a hot snare.
Okay, that's good. I think it's good to think about the different issues. You know, we thought about whether there's a cancer or not. Sometimes in a big polyp, it's very difficult to assess the whole thing. And the second thing is you wanted to prevent bleeding, so epi injection, and then use a hot snare. So all those things are good. So I want to go through what are all the different techniques that one can use to cut a large pedunculated polyp. So you could go in with a hot snare. Preferably better to use epi injection first. And sometimes you could use, when you have a large polyp and a relatively narrow sigmoid colon lumen, like if you don't have enough space, then you could use a long cap. The long cap is usually either a regular Olympus cap that you put outside a little bit by 3 or 4 millimeters and tape it, or you could use a band ligator cap that also works. Then you could use a loop, apply a loop followed by snare resection. You could consider epinephrine volume reduction. That is, you inject into the head and stalk, or stalk and head, and then give time for the epi to act. That means you go up to the cecum and come back. And during that time, the epi would actually make the polyp smaller. so that you could resect it. And then you could also consider applying clips to the base of the stalk. And then once you occlude the blood supply, you could use a snare for cutting. And sometimes you could use a clip followed by a needle knife cut. There are several different ways you could do when you look at the literature. These are some of the things that people have tried in the past. In the last, you could also use, and now there is electrosurgery scissors that is available, like the SB knife or the fusion on scissors type of knife that you could actually use to cut the stalk and then apply hemostasis. So in the last two sessions, we talked about loop application followed by snare resection. And that was session 22. And then session 23, that was last week, we used epinephrine volume reduction followed by hot snare. So here I want to share something different. That is basically using hot snare, epi injection, and then do it underwater. You may recall that Roy talked about this concept in one of the previous sessions. So, Seif, you said that you're going to inject epi. How are you going to inject epi? What dilution will you use? How much do you inject? And where do you inject?
I use 1 in 10,000, and I would go toward the base. I would move the polyp left and right to examine carefully the stalk, okay? And then I would go at the base, toward the base of the stalk, and I will start injection. Of course, it's preferably if you can inject 4 quadrants, but it's not necessary if you can achieve a good blanching with 2 or 3 spots. So I would try, because the distal, the proximal site of the polyp is going to be, of course, difficult. So I would try to inject above, below, maybe proximal to it, and I will wait to look for blanching in the stalk as well as the polyp itself.
Okay. All right, let's see what we did. So we went to the base of the polyp, and that's the base. We are injecting into the stalk, not necessarily into the wall adjacent to the stalk. So into the base of the polyp, close to the wall, and we injected actually 1 in 10,000 epi. I typically inject depending upon the size of the stalk. Here maybe 1 to 2 cc's, and then you see there's quite a bit of nice blanching there. And then for whatever its benefit, I also try to inject into the head, hoping that that might squeeze the blood supply in the head and make the vessels smaller. But in the epinephrine volume reduction technique that people talked about, the sequence that they followed was first inject the head and then in the stalk, and then go up to Cecum, come back. So once you injected epi, let's see, one problem is when you have a polyp that is hanging down, all right, the stalk is a little bit on the upstream, and then the head is on the downstream. So when you want to resect a polyp like this, and if you put a snare, and as you try to go with the snare around this large polyp, especially when there is not a lot of room, and as you move the snare with the scope, as the scope goes up, if in case you entrap part of the head in the snare, you may not realize that. And that's the problem by trying to put a snare from here up the stalk. So we decided, because that's a problem there, we decided that we wanted to push the polyp towards the cecum. So Seif, how are you going to push the polyp towards the cecum?
I would push it. I would try to put the cap. Sometimes you can suction the polyp and then push it slowly on the other side. Another way you can try, if you can do it with the catheter so that you're doing also under visualization, you can do that.
Okay. So you can maybe do different things. One thing is you could also try is put in a lot of water. And then with the water, as you can see, the polyp is floating, right? You see the floating of the polyp nicely, and then try to allow that floating polyp to help you push it up. As you can see, we are actually floating, and then it bent, the stalk bent on its in the middle, and then as we pushed it with water, we got it up. All right. Okay. So the next step is, how are you going to apply the snare? So Seif, tell me, how are you going to apply the snare? Are you going to come from top down, from the right side, or from the left side of the polyp? So 9 o'clock on the screen is left side, 3 o'clock on the screen is right side, 12 o'clock is the north side, and 6 o'clock is the south side. So how do you apply the snare, and how do you go about doing that?
It depends, of course, on the location of the polyp. If it's at 6 o'clock and I can have a good view of the other end of the polyp, which is the proximal part distal to me, and I would open the snare and I try to go top down, but I have to be sure that at least I'm not going through the polyp, I'm grabbing the stalk itself. But as I said, it depends on the location of the polyp. If I have a good location and it's in 6 o'clock, I can do that.
Right. So one thing is you have to keep in mind is where is the channel in your scope that allows the snare to come out. Sometimes the channels are, if it is a colonoscope that you pick, your channel is for an Olympus scope, it is around 4 or 5 o'clock. If in case you pick an EGD scope, because the sigmoid colon is narrow, then the EGD Olympus scope channel comes out on the left side. So that's something to keep in mind. Where is the channel coming? And if the channel is coming on the right side, it is much easier to come from the left side of the polyp. So let me show you that. Okay, you see that? We came to the left side of the polyp. The channel is at 5 o'clock. And I'm putting in water to allow this polyp to float. And I'm using a big snare, almost 25 millimeter snare. And as you can see, you can't see a lot of stuff with this polyp. And you want to make sure that your snare opens up wide and doesn't trap into the head of the polyp. And by allowing the polyp to float, you could actually get the snare around the head of the polyp and then gently come down. And the key is to avoid entrapping your snare into the head of the polyp. So as you can see here, we use the right to left and down technique. And then we use water to allow the snare to float. And the most important thing is, even if you take a little time, reopen the snare, check yourself a couple of times to make sure that the snare tip has not entrapped any portion of the head of the polyp. So that is really critical.
So Dr. Raju, I have a question.
Go ahead. Somebody's asking.
Yeah, Dr. Raju, this is me, Zubair. So when you opened the snare and went through the head of the polyp, at that time, were you constantly injecting water, or you already filled the sigmoid colon with the water and then opened the snare and went over the head?
I'm using water to allow to use the water to float, and see, I'm actually continuously pushing water to give myself some the force of the water to push the polyp head away from the wall. As you can see that, there's a lot of water floating through that, right? You see that?
Yes.
So here, if I close that, I would have actually entrapped the head. So I wanted to make sure that I go below the head of the polyp and then pull my snare back without closing it. You see that? So that I can actually make sure that I'm coming below the head of the polyp. Did you appreciate that?
Yes,
Right.
sir.
Using a little bit of water and to help you get through that problem. Right. So how are you going to cut this polyp? Are you going to use, what type of current are you going to use? And what setting are you going to use? Seif?
So as I said, I want to be sure that the patient is proper, has a proper padding. Until now, we're planning to do hot snare polypectomy. The settings for the electrosurgical unit, usually, I would say the standard is 313, so endocut Q. So I would use that, and it should, I anticipate, like, we have a good grasp of the stalk, and it should, sometimes we may feel resistance due to the center or the vessel, but it should not be that hard to cut it. So this is what I would use.
Okay. So let me ask the panelists, well, how would they cut this polyp? Sylvia. Any of the panelists would like to comment? How do they cut the polyp? What settings would they use? Roy, Sriram,
I never
Sylvia,
changed.
Ravi?
I
Sel?
never changed my setting, so
Okay, what
It's
settings do you use?
it's somewhere about 315, I think.
Okay. How about Sylvia? Because this is something important for people to learn, right? You know. Okay. Selvi?
Okay. So
Right.
the setting would be usually 313.
Okay. Okay.
Next week, I will share my settings. I will take pictures of all of the settings and share it. We haven't changed it for 10 years, honestly.
Okay.
Mm.
Okay. All right. I want to hear from Selvi and Sriram. What do they do?
We have different electrogenerators in different places. So personally speaking, for a polyp with a stalk as simple as in this one, I think the standard polypectomy settings should be okay no matter what generator you're using. So whatever is the, I would say there is no reason for changing the settings of the routine polypectomy for this particular stalk. And with the Olympus generator force coag 2, I would start with a wattage of 20, and if it doesn't cut, then I go up. I don't use for routine purposes. We don't have RB, so this is our go-to thing.
Okay. Selvi?
Raju, in the previous sessions that we've had, you've mentioned endocut Q316.
Yeah. Okay. I think that's reasonable. One of the things is I would like to just ask Sriram to comment. When there are different electrosurgery units in different places and people move from place to place, does it cause any confusion at all? In terms of the
I think
operator or the assistants?
I I think if the operator understands, the rest of the things will fall in place. And the other thing to understand is that, this is my personal opinion without any literature base to give it to you. But the other thing that is important is that as long as we are not doing the endoscope mucosal resections and but the regular polypectomy and a regular pedicle like this one, I don't think the generator makes that much of a difference. And if there is any, personally, when I see a new generator, I would go from lower settings of electrical current and slowly increase it as needed if the effect is not coming the way I would like to. Because you can always upscale, but not go the other way around because of the thermal injury that it can cause.
Okay. Yeah. One comment I would like to make is, just for the sake of the group, it's always important to keep things simple by having the same type of equipment in different labs under one roof, that is under one institution, so that people don't get confused if somebody comes and changes the setting and they're not used to that. So one thing to keep in mind is to keep it uniform. Less need to think through the various steps, because each generator setting is set up differently. Okay. So here we actually—
One of the other things, just a quick comment. So I think one of the things that happened with RB is that we have the thinking part has been transferred, the comprehension and thinking part has been transferred from the operator to the generator. And once the generator is changed, we need to think, then we are questioning our concepts about coagulation current and pure cutting current and things like that. So I think, as you have said in one of the initial sessions in the basic principles of electrogenerator, I think that reviewing that time to time is very important for our own comprehension. Then changing the generator, we are not confused. Whereas because otherwise, if we are blessed enough to have one place to work with and one generator to work with, that will be the best. But people do change jobs, go to different places. Things are not always under our control. So it is important to get the basics right.
Yeah, that's good. All right. So we here in this case, actually, we used this was actually a video that was done quite some time back. And at that time, for pedunculated polyps, I was using a forced coagulation, 25 watts, effect 2. And we are fortunate to have a nice cut with no bleeding. So once you cut the polyp, and the second thing is you have no bleeding immediately, what do you do next, Seif?
I usually examine the polypectomy site, be sure that I did not miss something. And of course, look at the base itself, be sure there is no perforation or something. And before I place any clips or anything, I usually do that. Maybe in pedunculated, some people may burn the edges, but I don't think this is the case in pedunculated polyp, especially if you have a good grasp of the stalk and you are sure that you did a complete polypectomy. I don't think I don't do that. I don't know if somebody's doing that or no. So that's the first thing usually I do after I complete the polypectomy.
Okay, that's good. So here what we did was, we cut the polyp, we cut the polyp quite a bit away from the head of the polyp. We got a nice cut, no bleeding. I think pedunculated polyp, you always worry about bleeding. So we're lucky to have no bleeding. And second thing is, like you mentioned, you look at the base. Usually pedunculated polyps, when you cut where you cut about 1/3 up from the base, the chances of perforation from a pedunculated polyp are extremely rare because of the stalk. So that is something to keep in mind. In the past, I used to worry and get my next device, that is mechanical hemostatic device, and go either for clips or loops immediately, because I do not want any of the vessels that has been stunned and went into spasm, reopen and bleed. So I used to be in a rush to do that. But one thing that I've noticed is once I put a clip or whatever, especially clips with long stems, they project up. Then whenever I try to go up after putting clips to pull the polyp down with a net or something, in the past, once I actually had my net entrap one of the clips, and I had to really struggle to get that clip out of the net to come out safely. So that experience made me think, why not take the snare that is still there in your scope? You didn't pull the snare out. After the cut, your snare is still in the scope. Reopen the snare and grasp the polyp with the snare and pull it down and bring it distal to the resection site. Or if it is very close to the rectum, I just pull it out and deliver it into the formalin jar like we're doing here. This is what I do to avoid myself getting into trouble if I used a net that caused entrapment, which happened. So now you come back and look at the base. What do you see and what will you do? Seif.
When I look at the base, as I said, we're sure that no bleeding and no perforation, although it's minimal here. And then I would like, since it's a big polyp feeding vessels and there is a risk of bleeding, I know we use the epi and at the same time we use the hot snare, but I would of course clip it, and then it's gonna, now depends what type of clips do we want to use, and I think it depends on the availability of the clips in each institution. Some people, like we have Dura and Resolution, mainly the ones that we use. So I like Resolution, so because I can control the angle and the direction of the clip by myself. So this is one thing I would use.
Okay. So you look at the picture and you tell me what you see. Do you see anything?
And this one, there is a red, I can see there is a reddish area in the center, which could be the feeding vessel at this part.
Okay.
Or it could be a tissue. I cannot see it appropriately, but I can see it. There is something here, definitely.
So the reddish tissue, you think it could be a feeding vessel. Could it be anything else?
Yeah, it could be a part of the tissue itself.
Yeah.
Yeah.
Could be the tissue of the polyp. You don't want, you want to look at the base to make sure it is clean and no polyp tissue. Vessels don't look this big. If you look at the vessels, caliber of the vessels, maybe not a bad idea for you to take time and go to a colon vascular anatomy article and read about the size of the vessels. It will be a good exercise. So here what we did was there's a small amount of tissue there. I don't want to put my clips and close that defect around. So I wanted to and have that embed and form my polyp tissue later. So I wanted to get rid of that. So that's what I'm doing, to just take it off, clean it off completely. So what do you do next in terms, you said clips, would you use a loop instead? And why do you use a clip? When do you decide to use a clip versus a loop? Maybe I ask Roy to talk about it.
Okay. Why would you use a clip versus a loop? Okay. The pros for the clip, let's talk about clip first. The clip, more people are familiar. It's easier to deploy. The cons would be you would need multiple clips because you need to do a zipper technique to close it. And another con maybe at the end, the cost would be a lot more. So the pros for the loop would be much more secure. It has more data to show that your risk of bleeding is 0 if you deploy it properly. The con would be many people are not familiar with deploying it. They are familiar with the concept, but when it comes to deploying it, they are not familiar. I think that's about it.
Okay. So Roy is going to show us a little bit more about the loop later on. So here we decided to put the clips, and like Seif talked about, I picked a resolution clip and tried to close the defect because you could have a finer control on rotating the clip so that you can get it across. And as you can see here, when we apply the clip, we're not applying it superficially. We're applying a deep approximation where there is no gap in between the two blades of the clip, as you can see here. And the second thing is when you're applying clip, you don't want to apply a clip on another clip because that's going to slip. So you want to take time and make sure that you create like a zipper type of a closure. And as you can see here, you don't see any gap in between the two blades of the clip once it is closed. And that deep approximation is what is important for a secure closure. So what do you do next? Seif, you got a nice polyp. You're happy that you came out with no bleed. Bleeding is a messy subject, you know, and you know that there's no perforation. So what do you do next? You got the polyp out.
We got the polyp. We're gonna examine the remaining colon, finish the colonoscopy.
This was already done before. So the guy actually had an exam outside. They had a polyp found. That's why he's in your endoscopy suite. So we finished the examination. We cut the polyp. What do you do next?
One thing usually, especially after if we did prolonged polyp examine, the patient belly is soft, and of course inject tab 2. Few centimeter away from the polyp, not close to the polyp, not on the polyp, of course. And the way usually we should inject saline first. This is how he taught me: inject saline, make a bleb, and then after that we inject the tattoo so that we can avoid spilling of the tattoo into the peritoneal cavity.
Yeah. So that's good. We need to put a tattoo because we were thinking, you know, Zubair talked about it, whether there is a concern for a malignant polyp here. And if it were to turn out to be cancer and with adverse features like a poorly differentiated cancer, lymphatic invasion, vascular invasion, or a margin that is too close, then the patient requires surgery, right? And if you have that suspicion, I think you, in order to avoid another procedure, you should tattoo not just one spot, but actually 4 quadrants, because that's very important to do that. On the other hand, if you think it is a benign polyp, and basically, I did not show the whole thing. You know, this came back as a benign polyp. If it is a benign polyp, you could just put one tattoo like we did. Unlike a polyp that you're going to send to somebody where you want to inject a little bit away, once you resected a polyp like we did in this case, you could actually use the fluid cushion that's already there from your prior epi injection, and then use that small amount of fluid that is still there and inject directly and put the tattoo. So first of all, I want to thank Zubair and Seif for joining, and you guys.
May I have a short comment, Professor Raju?
Yes, please.
In our experience, removing of large pedunculated polyps can lead sometimes to complications like burning of the bowel wall. So maybe you can comment on that, how to prevent it, and after resection of the polyp, I think as a last step, we could take a look to the larger area around the resection place to make sure that we didn't do any damage to the bowel wall.
Sylvia, it's a very important point that you brought up. I think I'm glad that you brought it up. It's a good principle to keep in mind, to check the opposite wall that there is no counter bone. One of the things that we talked about in the initial sessions was how to cut a large pedunculated polyp to avoid counter bone. If the area of contact of the head of the polyp extends over a large area, then the current density is still at your snare and you will not have a counter bone. So when you have a large polyp and you have the whole head touching a large area of the colon wall, that risk is not there. On the other hand, you have a polyp where the head is touching a small area, you should worry about it. And in those cases, either by filling it with water or having a larger area touch the opposite wall, or slightly moving your snare so that the head keeps on moving and there's no one point of contact, is another option to minimize that counter burn problem. Irrespective of all these things, it is a good principle, like Sylvia suggested, to examine that portion of the colon wall to make sure that we have not inadvertently caused a counter burn before we come out. I'm glad that you brought it up. Thank you, Sylvia. All right. So, if there are any other questions, all right.
I just have a quick comment on that same topic. As both of you suggested, I think keeping it at the back of the mind anytime we resect this kind of polyps is the key. The other thing I tend to do is to after applying the Snare before cutting, put in more CO2 and to distend the lumen to make sure that to understand how the polyp is, the contact surface is behaving, and if my snare is completely ensnared the stalk or not before applying the current. Sometimes when the polyp is very large, we think that the snare has snare properly encircled this stalk, but actually what happens is the far side of the polyp head, so if it is lobulated, it could still be sparing one of the lobules out of the snare, and that way it becomes an incomplete resection. So to avoid both the contact of the other areas, burn to the other areas, and also to make sure that the polyp head is completely within the completely snared, it's good to distend and make sure, especially these days when most of us are using water, people have a tendency not to distend the colon. And so it's important to emphasize the safety of distension and need for distension, especially when we're using CO2. The previous problems are no longer common.
That's good. Thank you, Sriram. So there's a question from Jaydesh about if the resection is incomplete in a benign polyp, i.e. dysplasia extends to the resected stalk, what would you recommend for repeat examination or for subsequent resection? I think once in a while I've seen a little bit of a polyp tissue that comes from the head to the stalk. And if I see that, what I do is I almost do almost like an EMR type of a resection. What I mean is I inject not necessarily into the stalk, but into the colon, colon mucosa, closer to where the stalk enters the colon wall, and inject a lot of fluid so that I resect the base of the stalk so as to avoid that polyp tissue getting into the margin of the cut. So I've actually seen that case. I don't know where I recorded. I do have a case like that where we injected and cut it. If in case you did not recognize that and you cut, and then after the cut you see some tissue there, what I would do is in that case, I inject some more fluid and do like a extended piecemeal resection of that base. I would want to complete that resection during that session instead of trying to bring them back. So that is something that I would do it. That is for Jaydesh. I hope that helps. The most important principles of resection, there are only two things I follow. Did I cut it completely? And did I cut it safely? And if I don't answer, if I finish my cut and I think it is an incomplete cut, and if I can safely cut more, I do that cut. So I want to get rid of it at that time so that you don't have to deal with a recurrence that is going to be very tough to resect later on. And Joseph's question was whether because of feeding vessels, one would use a larger interval between cuts. The answer is yes. But at the same time, you know, I did a case last week. It was a large pedunculated polyp. It's a very huge polyp. And I used a 316 cutting. Sometimes that 316 is still not good to seal the vessels. And I will actually bring that case because I had to deal with a very significant bleed during that cut using 316. And maybe you know, we're afraid of the burning of the wall with coagulation. So we are switching more towards the endocut Q. But, you know, sometimes when you do that, you have to be prepared for a bleed and control the bleed. All right, I would leave it to Roy. I think he's going to talk about a little bit about the loop. He wanted to share his experience. Roy, take it over.
Thank you, Raju. 3 weeks ago or 2 weeks ago, we talked about this case, and I'm going to share with you a comparative case so that perhaps we can emphasize more of the points that we wanted to bring up in terms of using the endo loop. So Raju talked about the importance of using water. This polyp is large, so it's kind of difficult to slip the loop, or it's even also difficult to slip the snare if you don't use water. The water makes the polyp to be floating. So here's a case whereby the polyp is big and there was no water use, and I wanted to just give an illustration of how difficult that could be. So this movie is cut, but you can see that it is not easy to get that loop to slip under. So had they used water, unfortunately I don't have a movie for this, but on the right upper, the loop just slip underneath the head of the polyp. Okay, so that's the importance of using water. When you use water, also you don't really have to worry so much whether the polyp is hanging or is from the bottom, from the non-dependent position or dependent position. As long as you can put your endoscope with the 5 o'clock direction in the direction of the stalk, then you can use the water. Okay, and we talk about the importance of using the sheath to the direct placing the loop. So here we say close plastic first, and then you close loops. So I'm going to give you a comparative case whereby the plastic was not used. And the movie will be in 2 parts. One is at the regular speed, and then we are going to have a slowdown of the movie, and you can see that the loop changes in its direction and actually did not stay at the bottom of the stalk anymore. So let's go look at this. You see that the loop moved to the left side. So this is slow motion. And the reason is that the loop tends to make a curve when it's being closed. And at the end, then the loop is placed a little bit too high up. You actually would want the loop to be placed at the bottom of the stalk. This is almost like 1/3 up. Ideally, it should be at the bottom. So many years ago, maybe about 15 years ago or so, we had described the technique of how to place the loop. So here's the movie of that technique. The first part of the movie showed like how you could get into this curving of the loop when you use the standard deployment technique that was prescribed by the manufacturer. So here it is. So the way you do it is that you bring the sheath back, and then you just close the loop, and you see the curl of the loop, and that makes that loop to move upward. And then at the end, then you release the loop. So the better way to become to place it more accurately is actually to advance the sheath first, so that you can adjust it and you still can open and close the sheath. So here, if you don't like it there, then you can reopen the sheath. And then when you close the loop, then you pull back the sheath slowly. This movie was made 15 years ago, so it's not very high resolution, but we will make a new one soon. At the end, then we test how firm it is, and then we release it. So that's very important, and by doing that, then perhaps we can be much more accurate in terms of placing the loop. And the third portion that we emphasized last time is the importance of understanding current density. So current density is current divided by the area, and the smaller area it is, the higher, of course. And the burn occurs when the current density is the highest. So here, when you have the loop at point B, and the area is very tight, if your snare is not as tight as the loop, then the burn will occur at the loop side. And if the loop side is very close to the wall, and you don't see, why is it not burning? Why is it not burning? And you just keep burning it, and your assistant just slowly closing the snare, then you could actually have a lot of thermal injury at the wall. So how do you prevent that? First, number one is that you need to make sure that your loop is very, very tight. So that if you cut at point A very fast, then you don't get any bleed because the loop is perfectly placed. So that's the key. And number two, to prevent burning at point B, you need to just tell the assistant close very tightly and then just cut quickly. Here is an example of the cut when it was done slowly. And please take a look at where the burn is. So the person is starting to do the cutting. That was measured about 7 seconds actually to do it. And you see that the burn is at the snare side, but there is also a burn at the loop side. And the reason why there is a burn at the loop side is that in the beginning, the area at the snare side was larger than the area of the loop side. So in the beginning, it was just burning at the bottom. And as you can tell, that it was hard to see under the snare. So this is not something that you would want to do. So this is a comparison of the cut site of a very quick cut. There is no burn at the loop side. The loop side is at the very bottom here at about 630 position. There's a plastic sheath of the loop, and there is really no burn there. That is a picture at the bottom, right bottom. While the picture at the right top, you can see that there is burn at the loop side. So we encourage people to make sure that you have a team that understand how to place the loop. And then when we cut the polyp, then we just do a quick cut. And we hope that by doing this, then more people can use the endo loop technique and prevent bleeding from post-polypectomy. We don't have in this collection of slides of the risk of bleeding after a proper placement of the loop, but that number is really zero. I believe a long time ago, we had calculated the confidence interval of such placement, and the number is still small. So there is enough data to suggest that if you can try to use the endo loop. The important thing is that to have the team ready on how to use the endo loop. Thank you, Raju.
Oh, beautifully done, Roy. I'm glad that you brought this thing up, because this summarizes a lot of points that we've been discussing over the last 3 weeks about loops. And I'm glad that you showed these two pictures, which tell us that you tighten the loop, but you tighten your snare much more than the loop to avoid the counter burn and cut fast. Thank you.
Thank you.
If there are any questions or comments,
I would suggest for the that was excellent, Roy. Really helpful. Once in a while, if in the beginning, if people are not obsessively careful when applying the loop after when you're cinching it, that in our eagerness to have the loop properly placed, if the pressure is too much, a thinner stalk can actually snare the polyp. So that is something to keep in mind. And the way to avoid it, personally, what I feel is to develop the tactile sensation of how it feels when you close and have what is a snug fit, what is the tightness that you feel. All these things, this kind of tactile sensation can be practiced outside, where like you showed with the pencil, so that the operator knows how much is too much and how much is there is something more to go. And I always make sure that The last part, I handle it myself.
So any other comments? Nicely done, Roy. I want to.
Hold on. Maybe I'll show what, just spending another second here. This is what Sriram was talking about. So here we show that the one way that you can understand whether is how much pressure is exerted is actually to loop your own finger. Don't worry, you can always take the loop off and then see like where does it feel, what does it feel like when the tip of the finger started to blanch. And you can feel that that there is a certain pressure for that, and you really don't want to make it higher than that. You really don't loop it to the point that you're screaming about having the loop there. It's just like spongy feeling, and that's what Sriram was talking about.
Yeah, that's good. All right, if there are no questions, I want to thank Zubair and Seif and my good friends Selvi, Roy, Sylvia, and Sriram for joining. Hope you all have a great Sunday. Thank you. Thanks, everybody.
Thanks, everyone. Bye, Raju. Bye, everyone.
Bye-bye. Thanks a lot, Selvi.